Welcome back, everybody. We are now going to be going over chapter 16, the last and final chapter. Good job on finishing the course. Everybody worked really hard in getting this done. So I am kudos to you. Just one more chapter to get through, then the final, then you guys will be done. So we started off in preconception, and now we're going back to that final passage of dying and bereavement. And if you remember at the beginning, I showed you that video, that little short clip of that video of the time lapse of the animation of the little baby crawling all the way up to the person dying. And so kind of that's what this development of lifespan goes, right? We start not being able to do a lot, and sometimes we get back and we go back, and as we get older, we get to that final passage, we get back to those stages of where physically, mentally, we regress and we kind of lose the capacity as if we were going back to when we were born. So it's a full circle here. So let's go ahead and dive into chapter 16, final passage, dying and bereavement. So throughout chapter 16, we're going to be looking at why is it so difficult to contemplate our death? What is the grief process like? And how do people in different developmental stages experience the death of a loved one? So if we look at the research and the studies, it seems like we are more bothered by the prospect of losing our loved ones than we do about our own selves dying. These studies also show that we worry more about the process of dying, the pain and loneliness involved, for example, than about the end of life itself. So it's actually the process more than the ending. In general, when we are asked if we are afraid to die, most of us deny it and report only mild levels of anxiety. The small minority who do report high levels of death anxiety are even considered psychologically abnormal, fear of death, and recommended for treatment. The 5 stages of grief and loss are denial and isolation, anger, bargaining, depression, and acceptance. In our bereavement, we spend different lengths of time working through each step and express each stage with different levels of intensity. So, contrary to popular belief, the 5 stages of loss do not necessarily occur in any specific order, and we often move between stages before achieving a more peaceful acceptance of death. Many of us are not afforded the luxury of time required to achieve this final stage of grief. Many of us, it comes unexpectedly. Please keep in mind that everyone grieves differently, and that some people will wear their emotions on their sleeve and be outwardly emotional, while others may experience their grief more internally and may not cry. As we learn, there's no right way to grieve. You should try and not judge how a person experiences their grief, as each person will experience it differently. So as we go through chapter 16, we're going to look at this bereavement process and not only how it affects as we go through death, but how death affects us when others die and in different stages of it. Social cultural definitions of death. All cultures have their own views of death. There are different rituals. Mourning rituals differ from culture to culture. For example, Orthodox Jews cover all the mirrors in a house. Ancestor worship in many Asian cultures. Look around your own families, your own people in your community, in your classroom. We all have our own background on how culturally or religiously we mourn death. And also some of the most famous structures on earth result from customs regarding death. So an example is the Taj Mahal, the Egyptian pyramids, where they laid the Egyptians would mummify, their people to lay them to rest. So death plays a big part in our social cultural environment. So let's begin and take a look at the legal and medical definitions. How do we determine that a person has died? So for many centuries, people accepted and applied the criteria that now define what is considered a clinical death, and that's the absence of a heartbeat and respiration. Currently, whole brain death is the most widely used definition and is based on 8 highly specific criteria. So other conditions that might mimic death, including deep coma or hypothermia, which is when your blood, when you get very cold and everything kind of slows really, really down. Drug overdose must also be ruled out. So they do like an ECG, where they test the brain waves and they check and see if you have a whole brain dead. So that means when you might have heard like if they're brain dead. So they do that very clinically, and they have to pass these 8 specific criteria. And if they're considered brain dead, then that's when they start talking about maybe organ donations and stuff. So let's take a look. No spontaneous movement in response to any stimuli. So no spontaneous respirations for at least 1 hour, total lack of responsiveness to painful stimuli, no eye movements, blinking, or pupil responses, no postural activity, yawning or swallowing, no motor reflexes. In addition, the lack of brain activity must occur in both the brainstem and the cortex. So they're testing the brainstems where all your autonomic, your breathing, your heart rate, all that. And the cortex is, where all our thoughts and our actions are come. So they're looking at both areas before they determine someone has a whole brain death. So like I said earlier, another test they do is the EEG, where it tests to see if there's any connections, any brain activity between there, and they use a EEG, and that flat EEG for at least 10 minutes shows that there's no connections, nothing happening in the brain. So no changes in any of these criteria when tested 24 hours later would make that person considered whole brain death. Whole brain standard is used everywhere in the United States, but it does not come without controversy. Some medical professionals call for a single assessment or a simpler one, and some religions find brain death controversial, so they don't believe necessarily that the person, is necessarily, controls their whole death. So again, but it's still the standard used in the United States, but it doesn't come without its own controversy. So let's take a look at another legal and medical definition: persistent vegetative state. So it is possible for a person's cortical functioning to cease while brainstem activity continues. So that's like that person's in a coma. There's nothing really going on in their brain, but they still, like the brainstem, like I said earlier, controls their heart and their breathing. So they're still being able to bodily move, but there's nothing, really going on in their brain. So again, it's a situation in which a person's cortical functioning ceases while brainstem activity continues. A person does not recover, does not allow for consciousness, which means like thought or purposeful, basically who they are. And family members face difficult ethical decisions regarding what to do for that person. So I've seen it in myself when I've treated patients. It's very hard to see that when you see them. It's their body is there, but their mind is not there. And I feel for the families, I feel for the medical professionals treating them, because what do you do when your body is still alive, but your brain is not functioning? So definitely ethical and medical things that you're going to have to deal with if you come into this field, or everybody in life maybe faces sometime, but definitely a situation that is not a clear-cut answers. Let's take a look at some of the ethical issues with death. There's a lot, right? Bioethics. So what is bioethics? Based on respect for individual freedom and the impossibility of establishing any single version of morality from rational argument or common sense. So basically, bioethics is the study of the interface between human values and technological advances in health and science. So with advances in technology comes more ethical decisions. Just because, like I've talked about in earlier lectures, just because we have a technology to do something doesn't mean it's the right thing to do. So how do we decide what we take the human aspect and we mix it with the technology? How do you make those right decisions? Well, that's bioethics. People must weigh the benefits and harms regarding keeping one in a persistent vegetative state, beginning risky treatment, etc. So again, more technology is awesome. It saves many lives, but also it has to bring us some really tough questions and some really tough decisions as family members and as medical professionals. So another ethical issue that is very in the forefront now is euthanasia, the practice of ending life for reasons of mercy. So usually in this scenario, when a person's being kept alive by a machine or has a terminal illness, should a person be able to make the judgment that another life should end? It's a hard question to ask, right? How do we decide when life is done? There are two types of euthanasia. There's active euthanasia, means deliberately ending someone's life based on the patient's wishes or by a decision made by someone else who has a legal authority to do so. So that may be physician assisted. Like the example here, they said administering a drug overdose. So that's something you'll talk about in your discussion group. That physician assisted, that case in the news with the hemioglioblastoma, that brain tumor that's nearly fatal, always fatal, but one of the worst brain cancers you could have, that was in the news. The young lady fought for physician-assisted, probably about 6 years ago, fought for physician-assisted suicide and had to go to Oregon where it was legal. So it's definitely something to think about. So we're going to discuss that in a discussion group, but that's active. It's like a physician-assisted or taking taking more of your pain medicine to ease the pain for mercy. We're going to take it on the next slide. We'll look at what passive euthanasia is. Passive euthanasia is allowing a person to die by withholding available treatment. So that would be like disconnecting a ventilator, not getting the chemotherapy treatments, etc. So in the hospital, I work at Memorial, what we do is the family, they decide it's called comfort care. And you're going to look at those in your videos today. You're going to look this week, you're going to look at what's the difference between hospice and palliative and comfort care. What does that all mean? Well, comfort care in our hospital means that we are going to make the person comfortable, and they've decided not to have any extra treatment. So basically, we just give them pain medicine to make them comfortable, but they don't get high flow oxygen. They don't get their treatment. They're not going to be ventilated. They're not going to. They may even take some of the oxygen away, anything to kind of make them comfortable because we know they're going to pass. So that would be an example of passive euthanasia. And you, as you become a nurse, and those who are not, so this is good to know, but that would be one of the things that that is actively done, in that realm of care in the hospital. There is controversy regarding whether there really is a difference between active and passive euthanasia. And many people in the United States have religious reasons for not supporting euthanasia, especially active forms. Globally, opinions about euthanasia vary and are often related to religious or political beliefs. So you guys are going to be talking about that a little bit in your discussion groups this week. So there's an article you're going to read and about the ethic dilemma and kind of the arguments for pros and cons. And I wanted to see what you guys' thoughts on. And again, this is a very, it's a hard decision until you've been in that situation and your loved ones and stuff. It's hard to make that. So we're going to look at that, be kind to each other, and it's definitely something that, is never easy. We'll look at euthanasia a little bit more. Western Europeans tend to view active euthanasia positively. Eastern Europeans and Muslims tend not to. Several countries tolerate physician-assisted suicides. The Netherlands is the first country to officially legalize the practice. And physician-assisted suicide, which I talked a little bit earlier on the other side, is a process in which physicians provide dying patients with a fatal dose of medication that the patient self-administers. So they just provide the medicine, but the patient actually does it, or the family member actually does it. So I talked a little bit about earlier in the U.S., Oregon and Washington allow physician-assisted suicide, but Oregon law seems to be implemented well so far and has psychological benefits per patient. A famous physician-assisted suicide physician, I don't know if you guys remember, it's kind of way back, but I remember it's during my time, Dr. Jack Kevorkian. He was the medical pathologist who willfully helped dozens of terminally ill people in their lives, becoming the central figure in a national drama surrounding assisted suicide. In arguing for the right of the terminally ill to choose how they die, Dr. Kevorkian challenged social taboos about disease and dying while defying prosecutors and the courts. He spent 8 years in prison. Can you imagine? 8 years in prison after being convicted of second-degree murder and the death of the last of about 130 ailing patients whose lives he had helped end, beginning in 1990. Originally sentenced in 1999 to 10 to 25 years in a maximum security prison, he was released after assuring the authorities that he would never conduct another assisted suicide. So I remember how controversial that was at the time, and it's a hot topic. So we're 20 years later now. What do you think the views are? That's something I'm going to kind of go over in your discussion group. What are the views? How do we do that? It's such a hard topic, right? It's such a hard thing to say when you're not in the position of that. And how would you react if you had a disease like you were going to die? So definitely not an easy thing to think about. There's pros and cons. So we're going to be looking at your discussion group and a little bit on the next slide as well. So what does the research find with what most people's opinions? So most people support it for terminally ill people in great pain. The Netherlands became the first country to officially legalize physician-assisted suicide. Oregon and Washington have laws that support it with some restrictions. So that's why I know that I was telling you about that story about the young, I believe her name is Brittany. We went up to Oregon because California doesn't have that law, or at least back then it didn't. 3 requests must be made by the patient spaced 3 days apart and screens for issues such as depression. So how do we make sure that the person is making this at a sound mind and not a mind that is sick and not able to make their own decisions? So what they found through the Kevorkian trials and all those assisted suicides, Kevorkian critics were as impassioned as his supporters, but all generally agreed that his stubborn and often intemperate advocacy of assisted suicide helped spur the growth of hospice care in the United States. And it's something that we're going to look at. Hospice care, like we think about saving lives, but how do we help someone at the end of their lives, to be the most functional, comfortable, these services are just as important. Palliative care, hospice care, making life, quality of life for your end years, how do we do that? It also made many doctors more sympathetic to those in severe pain and more willing to prescribe medication to relieve it. Right? Not everybody can be saved, but how we treat the patient and how we give them those last years of their lives is a crucial thing. And this has really sparked that hospice care and the quality of life for these patients as they get older and, as they start to have chronic diseases. In Oregon, Dr. Kevorkian's first assisted suicide patient, state lawmakers in 1997 approved a statute making it legal for doctors to prescribe lethal medications to help terminally ill patients in their lives. So that was 1997. And in 2006, the United States Supreme Court upheld a lower court ruling that found that Oregon's Death with Dignity Act protected assisted suicide as a legitimate medical practice. So definitely an ethical dilemma. But whatever your ideas on it, it definitely need to understand and how do we help these terminally ill or chronically diseased patients have quality of life and treat, maybe not to cure them, but to make the best of their end years. So this is a table of Oregon's DWDA prescription recipients and deaths, the Death with Dignity Act, and then how many deaths. So you can see in 1998, there's 24 prescriptions and 16 deaths. And in 2014, that's 6 times as many, 121 prescriptions and 105 deaths. So the ones that got prescriptions, most of them about, 80% actually use the prescriptions. So you can see that it's being used more. It's just something definitely an ethical decision and one that will be debated, but whatever side you're on is definitely a difficult decision either way. So let's take a look at a life course approach to dying. Why do most people start thinking about their own mortality at midlife? The kind of guess it's the halfway point, right? You start to reflect back on how you lived and you're realizing that you're in your later part. And they really start to think about how long they have left to live. It can lead to changes in occupation or strengthening relationships. In midlife, most people confront the death of their parents, and as a result, they have a growing realization of their own mortality because they can see them starting to get closer to that. Older adults are usually more accepting of death and less anxious about it than any other age group. Because maybe, the wisdom, I guess we can talk to older adults the wisdom of life being led and, the acceptance of having that life. So again, when you're younger, right, you still see, it's hard to imagine that. So let's take a look at that life course approach to dying. There are many ways of dealing with one's own death. Many authors try to describe the dying process using a metaphor or a trajectory that captures the period between the onset of dying and death. This trajectory of death depends on the type of illness. So you can see figure 16.2 in your book. So the green line is a clear and rapid period of decline. So this may be like the diagnosis of a cancer that, you're in stage 4 cancer and it just moves very quickly. A red line can be some periods of rapid decline followed by recovery, but with general decline over a period of time. So you could have a heart problem where you get better, but you're still, your heart's really, really weak. And finally, it just declines over a period of time. Or you can have a long-term chronic condition like COPD, some kind of respiratory that you have to deal with a lot of problems, but eventually, it will result in death. So depending on what type of illness you have, and that trajectory is going to depend on how you deal with your own death. So when we think of dealing with one's own death, we think of Elizabeth Kubler-Ross. She described the 5 ways that people deal with death in her book, Death Not Be Proud. And I talked a little bit about this in the introduction, the 5 stages of denial, anger, bargaining, depression, and acceptance. And again, people may be in more than one stage at a time. They do not necessarily go through all of them or go through them in the same order. Core identified 4 dimensions of the types of tasks people must face. So Kubler-Ross thought of the reactions, and core is kind of the tasks. So the bodily needs, the psychological security, interpersonal attachments, and spiritual energy and hope. Core believed a holistic approach that recognizes the coping efforts of family members and caregivers as well as the dying person. And then there's Kastenbaum and Thule, who emphasize the socio-environmental context within which dying occurs. They argue that the social environmental context within which this dying occurs often changes over time and must be recognized. So for example, does moving from an independent living to an assisted care facility influence how the person copes with dying? If they're at home with family opposed to in a skilled nursing facility. So again, just like we looked at, other parts of development and how socioeconomic faces it, death is another part of development, and that socio-environmental context is still playing a part in how we view and deal with dying. So death anxiety is people's anxiety or fear of death and dying. Researchers apply terror management theory as a framework to study death anxiety. The theory addresses the issues of why people engage in certain behaviors to achieve particular psychological states, based on their deeply rooted concerns about mortality. This theory, though, assumes that a person's primary motive is continuing his or her life. So they're just looking at how are they managing this fear of death? What behaviors do they use to achieve this, concern about mortality? So this is a picture of soldiers, right? So they face death on a regular basis. And facing death on a regular basis often forces people to confront their death anxiety because they're faced with it every day. You can think of a lot of professions like that, but very something that they deal with all the time. So neuroimaging research supports the use of terror management theory to study death activity. Brain activity in the right amygdala, cingulate cortex, and the right caudate nucleus is associated with death anxiety. So they can actually see it on a neuroimaging. So why might people express different feelings about death in public as compared to their thoughts when they are alone? Some degree of death anxiety is appropriate, but too much can interrupt daily function and routines, right? So if you're so anxious about, fearful of death, you can't function in a normal life. You can't get over it, right? Like that fear can cripple you. The components of death anxiety include pain, body malfunction, humiliation, rejection, non-being, punishment, interruption of goals, being destroyed, and negative impact on survivors. So think of anybody that's come from war or been in traumatic, police officers, or anybody that's kind of had some kind of faced their death in that way, or faced on a daily basis, can actually become crippling because that fear can be so overwhelming that they can't do their daily activities, which maybe us or people that don't have to face that, we can push that fear to the back of our mind because it's not a daily confrontation. So definitely interesting, and they can actually see it in the neuroimaging. So how do people deal with death anxiety? So teenagers often engage in risky behaviors. We learned that early on, right, in this semester. They live life to the fullest. Exercises such as writing your own obituary can help lower death anxiety. And death education programs exist to combine presenting factual information about death and reducing people's fears and anxiety. So each of those components can be assessed on 3 levels: public, private, and non-consciousness. So things that we just don't even realize what we're thinking about. And what do we say to our friends and family, and what do we think in private? So learning to deal with all aspects of that can help us, is very important. Learning to deal with death anxiety helps live life to the fullest. So just like, teenagers do, maybe not such, risky behaviors, but be smart about it, but to still live life to the fullest. To be able to write your own obituary can relieve some of that anxiety. Planning your own death and funeral service, and exploring death education programs. So learning to deal with that and releasing some of that fear of it can help deal with that death anxiety. End of life issues. Again, most people want to discuss arrangements if given the chance. It allows one to consider traditional care and alternatives, and people can make a will to make sure their wishes are carried out. So people who are dying must create a final scenario so that they can, die with dignity or control some aspects of their death. End of life issues include management of the final phases of life, after death disposition of one's body, and memorial services, and distribution of assets. And by able to doing that before, it can relieve a lot of anxiety, and it can help the family deal with their death after it happens. So we talked a little bit about that final scenarios. People making their choices known about how they do and do not want their life to end. And what that does is it allows them to, control some of the aspects of that. We talked about that dying process. They want to, so part of that final scenario could be affirming love and resolving conflicts in relationships, which is an important part of this process. Healthcare workers recognizing the importance of the final scenario and giving patients the chance to create one. So I can say from working, in this time during this COVID pandemic, having patients not having visitors in the hospital, and sometimes, a lot of these patients are dying by themselves, and it's very, very sad aspect. So when we know and we have time to allow that final end scenario, it's one of the jobs that healthcare workers are having to do, especially more than ever, because there aren't visitors in there. So making those arrangements to allow that family member to come in, to have time, to say goodbye, resolve these conflicts is huge. So definitely see it now more than ever, because a lot of people are dying without their family there. And it helps family and friends to interpret the person's death and open communication. And what they found is one of the most difficult and important parts of a final scenario for most people is the process of separation from family and friends, right? And worrying about how their family and friends are going to be affected by their death. It's definitely hard. Definitely a hard process to go through. So deciding whether to have a traditional funeral is part of the creation of one's final scenario, or maybe to be cremated or just have a wake. So that's part of that control of over your dying process. I mentioned a little bit earlier about hospice, but let's take a look in to what really is hospice and really understand the difference here. So hospice is an approach to care that emphasizes pain management or palliative care and death with dignity. So in the videos this week, you're going to learn a little bit about what's the difference between hospice and palliative care. And it aims to make the person as peaceful and comfortable as possible, but not delay an inevitable death. Palliative care is the relief from pain and other symptoms of disease during the disease process. So there's a TED video I have you going to watch, and it really discusses the importance of palliative care and making that wishes of the patient what's important to them and in trying to achieve that through the medical care. And it focuses on the client and family. It helps them to approach death. The hospice program is markedly different from hospital or home care because it's helping them be comfortable through a chronic or illness that eventually, will result in death. And I will say people come often on and off of hospice, especially a lot of respiratory people that maybe have hospice doesn't mean you're going to die in 6 months. Some do, but some it could be longer. So it's definitely a great service for our patients, but it's important that we understand what exactly the services are. So how is hospice care different from care a patient receives in the hospital? Hospice care when there is a life-limiting illness, so like COPD, cancer, other things that is going to limit your life that needs extra attention. It's not something that may get better. Its trust in one's physician is important in selecting hospice care. You need to have a doctor that understands this type of medicine. And 2/3 of hospice patients are over 65. So people usually decide on hospice care when they have a life-limiting illness, cancer, AIDS, cardiovascular disease, or other terminal conditions. People come on and they go from hospice care as their conditions change. So I have known some, especially COPD or constrictive pulmonary disease patients, where they come to the hospital and they decide they don't want to be on hospice because they want to have more measures. They want to maybe go, on high flow and have some of those extra measures. So it's a hard decision, and sometimes those are those chronic illnesses, and sometimes you're on hospice care for maybe 2 weeks and you pass. So there's a different level of hospice. There's a variety of patients. Some are on it longer, and some on it less, and they do pass faster. But it's definitely for those diseases or life-limiting illness that is going to have you want to let them be as comfortable and productive in their final years of life, and this is what that hospice care is going to manage. So although hospice is a valuable alternative, it may not be appropriate for everyone. Hospice provides supportive follow-up services to surviving family and friends. So this is a picture of a patient that is on hospice being taken care of at home. The hospice care comes to the home, helps the family. It's a great, great service. But like I said, it's not for everybody. So let's take a look at that. So what do families need to consider before choosing hospice? Is the person completely informed about the prognosis of their condition? What options are available at this point in the progress of the disease? What are the person's expectations, fears, and hopes? And do people in the person's social network communicate well with each other? So why are all those questions very important? Because even though hospice is a great service, it does have limitations on what life-saving measures can be taken. Hospice provides loads of support, but if the primary client, the patient, is not ready to halt anything other than palliative treatment, so remember, you may not get dialysis, or you may not get you're not going to get your cancer treatment, So you've got to remember, are you ready for that? Then hospice is not your choice, Pain control, comfort measures, familiar and pastoral support are common assistance, social services. So you have all these great services, but you have to be ready to come to that point that you're not wanting to try other options to save you. So this is a point in the disease process where you're not going to be cured. You're not going to be taking those saving measures, those chemotherapies. You're going to die with dignity. You're going to die comfortably. You're going to make that process. So if you're not ready for that yet, hospice is probably not the choice for you yet if you're still looking for those saving measures. Now, sometimes, you can still get some treatments on hospice. You have to definitely look into that further, but it's definitely those questions that you need to be asked, and the family needs to be on the same page, and there needs to be this expression and full understanding of exactly what hospice is before going on it. So what do families need to consider? Are family members available to participate actively in terminal care? Is a high quality hospice care program available? And is hospice covered by insurance? Will the care be provided in the home, or will the client be moved into a setting like long-term care or actual hospice home? So there is, we have a hospice here that you can have actually be at their facility. I've seen hospice at skilled nursing facilities, and I've seen hospice at home. We have patients at hospice in the hospital. Some of them still get physical therapy because they want to, maybe they just want to transfer to the commode and be able to go to the bathroom for as long as they want to. So we just reach out and what are their goals. So it doesn't necessarily mean that I'm not going to see them, because there's still some things that I can help them with just to maintain where they are. So traditional medicine has been influenced by hospice, pain management interventions. So that definitely, through managing these end-of-life terminal diseases, traditional medicine, people are getting better pain management as a result that are not in hospice. And hospice is covered by many health coverage programs, but there may be an out-of-pocket expense. So that definitely is a consideration for families, is if they do have that, can they afford it? So thinking about end-of-life matters raises complex legal, political, and ethical issues. It is essential that people make their wishes known. Most people fail to tell family members what they want to happen to them at the end of their lives. So how does one make intentions known? So there's two big things: a living will and a healthcare power of attorney. And most of the times too, when you go to the hospital, they make you sign an advance directive so that that you can express your wishes in writing, and it's in the chart so that there's no question. I know when my father was diagnosed with Alzheimer's, that was one of the first things that we did, is because he's still lucid, he can still make that decision on what we want to be done. Do we want to have, when do we want the ventilator? When do we want a feeding tube? Those questions, how do you want that care managed? When is it okay that we don't want those things, but we still want them as long as he's, brain is active and he's active. So it's a complex decision. So you need to make your wishes known, and as soon as when that person's of sound mind. So there's two ways to make their intentions known: a living will, in which a person simply states his or her wishes about life support and other treatments. And then a healthcare power of an attorney, in which an individual appoints someone to act as his or her agent for healthcare decisions. So my family, I'm considered the healthcare power of attorney for my father, because my mom doesn't want to make those medical decisions, and she's trusting me. So that would be something that I'm responsible for. So if anything happens down the line, then I am in charge of making any medical decisions. So those are some things that you wanted, that a person can do to help that end of life intention be known. So in order for these legal methods to work, relatives and physicians must know about the existence of these documents and where they are. So many of you may have heard of a DNR order, which is a do not resuscitate. So again, if something like a code blue or someone goes into cardiac arrest, they're going to want to do CPR or ventilate. So this means that do not resuscitate. So the medical team will not initiate CPR. So a living will or durable power of attorney for healthcare can be the basis for a do not resuscitate order. So again, that means that cardiopulmonary resuscitation, CPR, is not started should one's heart and breathing stop. And most ambulance and fire crews will ask on arrival and will look in obvious spots on the refrigerator near a phone. So that's one thing you can have. So if your family, if you have your family or something in a situation for your information, you just you can get it's an advanced directive. You can have it at home. We have it for my father. So you can just put on there, do not resuscitate. So if someone, they call and someone, they don't want that, you can just show the ambulance. If they don't have that, they don't know what the will of that patient is, and they have to err, obviously, in saving their life. So it's the power that you can have to help make those life decisions, and when you're not with it. So one major concern regarding end-of-life decision is cognitive or legal ability to make the decision. So we talked about this earlier with physician-assisted suicide, and filling out these direct orders, these directives, these advanced directives, these wills. It's imperative that when you know your wishes, or your family member knows his wishes, they need to do it when they're cognitively aware and can be upheld of sound mind. So cognitive or legal ability to make the decision. So they have to be proved that the capacity to make decisions is a clinical determination, so that they've determined that they're sound mind, and that the competency to make decision is decided by the court. So if it ever comes to that they can prove that these decisions were made with a sound, cognitive, intact mind. Surviving the loss, the grieving process. So it's always difficult as we survive, being the survivor of a lost loved one. So there are definitely different parts of that process, and we're going to look at it. And again, like I said earlier, the grief process varies by individual. So the three parts here are bereavement, and that's the state or condition caused by loss of death, and the state or fact of being denied the presence of something or someone. Grief is the sorrow, hurt, anger, guilt, confusion, and other feelings that arise after experiencing a loss. Deep and emotional distress caused by or as if by bereavement. So the bereavement is the state, and the grief is the actual emotional part of that. So bereavement can cause grief. And mourning is the outward sign, such as black clothes or an armband, of the grief for a loss. So mourning is highly influenced by culture. So what are culture expectations? A lot of times that people mourn in a certain way that is expected by the culture, and when that mourning is not falls out of that, people get very uncomfortable. They don't know what to do, and it's not wrong. Mourning can't be wrong, but it's often people try to express that in what's an accepted cultural way, so that they're not looked upon, in a unfavorable light. So again, the process of grief, it varies by individual, and it's it highly influenced by our culture, and it an experience widely ranges from person to person. So there is no right way to grieve. However, all of us who have felt grief, we confront similar and certain issues. And unlike bereavement, over which we have no control, so bereavement is just the loss, it's what happens, right? Grief is an active process. It's how we personally deal with that loss, with that bereavement. And it involves choices that we all have to face. Acknowledging the reality of the loss, working through the emotional turmoil, adjusting to an environment in which the deceased is absent, and loosening ties to this deceased. So how do people go through that? It's very individualized, and there's no right or wrong. And, no right set of time either. So, but realizing that grief is an active process that we all face, but it's the choices that we make in coping that vary from individual from individual to individual, and there is no right way to grieve. So grieving is a highly individual experience, like I just said, and there's no right way to grieve, and grieving does not have clearly demarcated stages. Grieving is an individual process. People need to have at least a year to begin recovery, and 2 years is not uncommon. People usually do not recover from the loss, they learn to live with it. And it is helpful to let a grieving person know that you are sorry for his loss, but you are there for support and that you truly mean it. So dealing with death of friends is often difficult. So we're talking about that lifespan perspective. So especially from young adults or adolescents, dealing with the death of a friend or someone close to them is often difficult for young adults. So there are many types of typical grief reactions: sadness, denial, anger, loneliness, and guilt are typical reactions to grief. The psychological side of coming to terms with bereavement is called grief work. So how do you do that? Experience of grief tend to involve coping, affect change, narrative, and relationship. Survivors need time to express the many feelings that they have. And again, those 5 themes emerge through the process that dealt with one's feelings as a survivor and their memories of the deceased person: coping, affect, change, narrative, and relationship. There's also a physiological reaction to grief. Sleep disturbances, neurological circulatory problems have been reported among widows. There's even that broken heart syndrome where they're so saddened that their heart stops. So, we've learned through, and I've learned through being in medicine for, 20 years, that mental can have so much, your psychological effect can have so much on your physical health and how you recover. I've had patients that have been positive and, psychologically, confronting their illness, and I have patients that just can't deal with it and they deteriorate. So I truly believe your psychological manifestation, can definitely have a physical reaction, and grief is no different. Another thing is your anniversary reaction, right? The term anniversary reaction refers to changes in behavior related to feelings of sadness on the anniversary of a death. It brings up the memory, right? Grief can last a long time. It comes in waves. You could be better one day and be, stricken down again. But most people move on with their lives in a relatively short period of time, which is just a necessity sometimes, but that grief is still there. It doesn't ever really go away. You just learn how to deal with it and move on with your life. We're going to look at some typical grief reactions and how openly grief is expressed varies considerably across cultures. So there are 2 interactive approaches to grief: 4-component model and dual process model. In the 4-component model, understanding grief is based on context of the loss. Context is the step that hooks 2 things together. Continuation of subject meaning associated with loss. This can range from evaluations of everyday concerns to major questions about the meaning of life. Thirdly, changing representations of the loss relationship over time, the getting on with it phase. And lastly, the role of coping and emotion regulation process. That's achieving, restoring, and sustaining psychological well-being. So implications of this view are that helping a grieving person involves helping them take meaning from the loss, and that encouraging people to express their grief may actually not be helpful. An alternative view called the grief work as rumination hypothesis not only rejects the necessity of grief processing for recovery from loss, but views extensive grief processing as a form of rumination that may actually increase distress. Let's take a look at the 4-component model. And dealing with grief is a complicated process that can only be understood through complex outcome that unfolds over time. Helping grieving people involves helping them make meaning from loss, and encouraging people to express grief may not be helpful. So that's what you want to take away from that 4-component model. So remember, I talked about that alternative view called the grief work as rumination hypothesis. It not only rejects the necessity of grief processing for recovery from loss, but views extensive grief processing as a form of rumination that may actually increase distress. So they feel like the grief work hypothesis believes that too much talk or too much processing actually can cause more distress. The dual process model, DPM, of coping with bereavement integrates existing ideas regarding stressors. So it defines two broad types of stressors. Loss-oriented stressors are those having to do with the loss itself, and restoration-oriented stressors are those relating to adapting to the survivor's new life situation. So you have the loss and then the adaptation. So again, the dual process model believes that dealing with stressors is a dynamic process. So see figure 16.4 in your book. And it explains how it is possible for people to be overwhelmed with grief one day and handling life well the next. The distinguishing feature of DPM is that it shows how bereaved people cycle back and forth between dealing mostly with grief and then trying to move on with life. So again, grief is not that straight arrow healing. It's not like how we heal physically. There are good days and we have bad days, and there are triggers or stressors that bring on a bad day, and there might be something that brings on a good day. But grief, that dual process model, explains how that can happen. So this figure shows the dual process model of coping with bereavement, and it shows that relationships between dealing with the stresses of the loss itself, loss-oriented, so that's the grief work, intrusion of grief, breaking bonds, ties, relocation of the deceased person, denial, avoidance of restoration changes, and moving on with life, which is restoration oriented, and that's attending to life changes, doing new things, distraction from grief, denial, avoidance of grief, new roles, identities, relationships. So you can see how it just goes back and forth, back and forth. Life is not straight. We have different stressors. We have good days, bad days, and same thing with coping with grief. And that's what that dual process model shows us. When a person never has closure and the grief continues to interfere indefinitely with their ability to function, that individual has complicated or prolonged grief disorder, which is distinguished from depression and from normal grief in terms of separation distress and traumatic distress. Symptoms of separation distress include preoccupation with the deceased to the point that it interferes with everyday functioning, upsetting memories of the deceased, longing and searching for the deceased, and isolation following the loss. So those are who the grief just overwhelms them. They isolate them from their friends and families, and they seem to not be able to let go and live in the present. So that's separation distress. Symptoms of traumatic distress include disbelief about the death, mistrust, anger, and detachment from others as a result of the death, feeling shocked by the death, and the experience of physical presence of the deceased. For some people, feelings of loss are debilitating and don't improve even after time passes. This is known as complicated grief and is sometimes called persistent complex bereavement disorder. In complicated grief, painful emotions are so long-lasting and severe that the individual has trouble recovering from the loss and resuming their own life. So how might complicated grief cause problems in social relationships? The death of a loved one is very difficult. And if you get into this, complicated grief, it's hard to continue on with social relationships or continue living in the present. So definitely it's a time to seek help to help you get through this, to come back and, be able to continue, your life and your social relationships, even while dealing with grief. There might be a point at this time that you need to seek outside help. American society tends to distance itself from death, uses euphemisms such as passed away, eliminates many rituals. So how can people learn about death in its natural context? Experienced death is the only natural context loss of loved ones may come after experiencing the loss of a pet. There can be a correlation between those losses in the younger age groups. Preschoolers tend to believe that death is temporary and magical, something that comes to get you in the middle of the night like a burglar or a ghost. The child, 3 to 5 years old, and a child at this age is egocentric. So remember that, right? Child focus, believing that the world revolves around them. The death of a loved one will be very self-focused, where the child believes that they are responsible for the death. They might feel abandoned, and the grief of losing a loved one as part of a disaster or crisis event may interrupt age-appropriate activities and force the child to address issues for which the child is not developmentally prepared. We know that from our studies, right? They don't have the cognitive brain to understand the process of death and the emotions associated with it. Emotions presented can vary greatly from sadness, anger, anxiety, and guilt. So as the child develops, when grown to 5 to 7 years of age, we can remember now as through development, children realize that death is permanent. So they remember that. It happens to everyone and biological functions cease to exist. Cognitive language abilities, psychosocial development, and coping skills are involved in this understanding. Bereavement in childhood does not usually have long-lasting effects, and their openness and honesty about the meaning of death are important. So in the child 6 to 12 years of old, school-age children at this age learn basic skills but attach their cultural values to it. Death of a loved one during a disaster or crisis event can result in a child not wanting to leave home, hoping to reassure the safety of others. So it's very literal, right? We learn that it's very, very literal. They can't think in the abstract. So you may see some of those things. And definitely when you're thinking about death and you're thinking about how across the lifespan that we react to it. So think about children, it definitely depends on their cognitive social development and how we recognize those signs, because we understand their development can help them process this more appropriately. So how do we do that? For the school-age child, like the younger child, grief crisis may interrupt age-appropriate activities and force a child to address issues for which the child is not developmentally prepared. Children this age might believe that certain behavior will bring their loved ones back. They might be preoccupied with fear. They might also experience sadness, anger, anxiety, and guilt. So explanations regarding death should be kept simple to facilitate understanding. Children need to know that it is okay to feel sad and show their feelings. And researchers believe it is important for children to attend the funeral of a loved one or have a private viewing to show the closure of it. So this figure shows that children show their grief in many ways, including physiological, which is somatic. So you can see sleep difficulties, refusing to eat, bedwetting, headaches, stomach aches, serious illness. So we talk about that physical manifestation, right? And sometimes they will regress developmentally. And you see some of that. Emotional, which is intrapsychic, and that's emotional distress, separation anxiety. They may not want to leave their close loved ones, fear that others will also die, death fantasies, learning difficulties, guilt, school phobia, or severe depression. And behavioral, aggression, explosive emotions, acting out, temper tantrums, extreme shyness, disinterest in play, overdependence, demand for attention with maybe some delinquent activity. So again, they're dealt with a very adult topic, yet they're not cognitively or emotionally able to handle that yet. So these are some of the ways that you will see that manifest in children through their grief. Adolescent, 13 to 19 years old, their more than school-age child often deal with self-esteem and identity issues. So we want to think about that development and how would death affect them. They want to differentiate from their parents. If they lose a loved one during a disaster or crisis event, they might feel guilty because of what they might have said to the person before they died. Adolescents, just like the young and the school-age child who experience this kind of loss during a disaster or a crisis event, may experience an interruption of age-appropriate activities, since this kind of loss can force an adolescent to address issues for which they are not developmentally prepared. Adolescents often express their grief and loss issues through their body language and acting out behavior. In addition, adolescents might be internally preoccupied with death, which might be manifested through poor school performance. So again, even though they're older, they still have some of the same problems as an adult. As a child, acting out, regressing. 40 to 70% of college-age students experience of death of someone close to them. That's a lot, and I know that it's definitely a hard thing to go through as a young adult. Teenagers sometimes have trouble making sense of death. And bereavement sometimes involves chronic illness, guilt, low self-esteem, poor school job performance, and substance abuse. Particularly if the loss was unexpected, personal growth usually follows long-term. So that's why it's so important that we help the adolescents through this time of bereavement. The young adult, 20 to 40 years old, death can be devastated. Young adults can be devastated by the death of a loved one during a disaster or crisis event. For example, losing one's child can be paralyzing for parents. Parental grief can be a long-lasting and powerful experience, and is influenced by the developmental tasks expected by the parents. The parents might blame themselves for not protecting their child better during the disaster or crisis event. Their emotions might range greatly and include such things as loneliness, sadness, disbelief, anger, anxiety, etc. Young adults losing a spouse or partner might feel emptiness and isolation, and their social connections might change as they are no longer a couple, but an individual. Losing a spouse or partner at this age means not only grieving, but assuming the often unfamiliar responsibilities and roles of the deceased. It may include helping children through grief. So they have to not only deal with their own grief, but have to help children through grief, which is double-fold. So many young adults believe that their peers who die are cheated out of their future. Losing one's partner in young adulthood is very traumatic and usually unexpected. Desire to stay connected through memories. They don't want to lose that person. Must challenge basic assumptions about the self, relationships, and life options. And the surviving spouse usually starts transforming perspectives by the 1-year anniversary. So definitely young adulthood, having a peer or a spouse die is very, very difficult. Becoming a widow as a young adult, as we know, can be very traumatic. Losing one's child is perhaps the worst type of loss. Many parents never recover and may end their relationship with each other. It might be the deciding, drive them a wedge between them. High anxiety, problems in functioning, and disrupted relationships with other children are common problems, depending on the cause of death. They may lose the bonds with their other children that are alive, dealing with their grief. And parents who lose children through stillbirth, abortion, or neonatal death are often overlooked, but still, are experiencing the death of a child. The middle-aged adult, 40 to 60-year-old. Middle-aged adults, similar to young adults, can be badly impacted by the sudden loss of a loved one during a disaster or crisis event. They might grieve the loss of their child or children and possibly the potential future grandchildren. The what if. They might feel guilty for not having been able to protect their child or children. Losing a spouse or partner during a disaster or crisis event can leave middle-aged adults with often unfamiliar responsibilities and roles. Maybe they're taking on the finances or, dealing with all the bills. All that stuff can cause stress on top of the grieving process. Experiencing financial hardships and are dealing with grieving children. So they're grieving themselves, they have these financial problems, they have to take care of the estate, and then their children are grieving. So a lot of things to deal with, and they're, grieving themselves. Middle-aged adults might grieve future plans for retiring together, the what ifs, their life plan is completely gone. So how do they reconcile that and go through, grieve and come out the other end to go on with their life. So definitely a difficult situation, and grieving, losing anybody at any age, is never easy. And it's important that we just understand developmentally why and the reasons why at each stage of their life that grief is difficult, and how by understanding that, then we're able to help people better cope and get through this, and give them the skills that they need to continue to live and be productive. And sometimes that's the hardest part, is going on when someone you love has passed away. So definitely important to understand the development of across the lifespan, especially when dealing with death. Losing one's partner often leads to redefining relationships with other family members. Losing a parent at a young age can lead to worries about dying young. You've experienced it, so you can imagine it. Whereas some other kids, they don't see that, they don't even think about it. And when an older parent dies, the adult child is usually more accepting of death and happy that the parent's suffering is over. So, if your parent is 95 years old and is in a lot of pain and they pass, you're sad that they're gone, but you're also more accepting because they lived a long life, they were suffering, and they're not suffering anymore. Opposed to if your parent was 60 and got in a car accident and it was unexpected. So the cause, the age, all those things can affect how we grieve and how we process them. So the late adulthood. Older people usually experience death of those close to them as traumatic. The loss of a child still causes intense grief that can last decades. It affects relationships with surviving children, and losing a grandchild also causes emotional upset, guilt, and regrets. They tend to control and hide grief behavior to shield their children, which is the parent, when they lose their grandchild. So this is the 60 plus age group. Elderly adults, depending on their age, have acquired memories, cognition, material things, accomplishments, spiritual realizations, and losses. They often have experienced multiple losses, right? They've lived a lot through life, a lot of experience, such as jobs, health, independence, social roles, familiar living surroundings, and loved ones. Although loss is often expected during this age, unexpected loss of a child or children, or spouses or partners during a disaster or crisis event can be detrimental. Since children are often also caregivers, right? So they lose not only the child they love, but the person who's going to take care of them. So that anxiety of how are they going to take care of themselves as well. Loss of a spouse or partner might result in feeling more dependent on others. And it's often the elderly adult lacks the social support needed, which can be detrimental during this time, right? They may have friends and family that are no longer with them as well. So definitely they have issues itself. How is you think of a child who's going to take care of a child, but sometimes it's the same thing. Who's going to take care of this older adult who lost their spouse, can no longer live by themselves, or they've lost their child who was helping take care of them, and they're dealing with grief, and they don't have the resources of social support to take care of themselves, so they may go into a facility. So they're dealing with grief and the loss of their life as they know it. So definitely, even though death can be more expected as they get older, but anytime that death of a child, grandchild, spouse, it's never easy. Losing a partner in late life is a deeply personal loss. Grief can occur for as long as 30 months. Survivors with close confidence are better off than those with many acquaintances. So it's better to have a few close friends that can really help you through the grief than just knowing a lot of people that may not be there when, to help you through that. And bereaved widows and widowers tend to give their marriages more positive ratings than the non-bereaved. And that makes sense because you want to remember that person for the positives and not the negatives, to help you get coping and move on. So figure 16.5 talks a little bit more about that in your book. Again, the loss of a spouse or a partner can be especially traumatic after a long relationship. I know after my My grandparents were married for 67 years, and he knew her for more than his whole adult life. So very difficult transition after that. What do you do when you've been with that person for so long? So definitely can be a traumatic after a long and even a short relationship, but definitely after a long relationship, because your identities are tied together. So who are you, that person, when they're not there? So what they found is that older women tend to sanctify their deceased husbands. It serves to validate that the marriage was strong, that the widow is good and a worthy person, and that she is capable of rebuilding her life. And they found that gay and lesbian couples often face other feelings and reactions on top of normal grief, because family members may not make the partner feel welcomed at the funeral, and makes achieving a sense of closure difficult. So, as we conclude this chapter and this course, we want to understand that death through an interaction of psychological and social cultural forces. So it depends, depending on your lifespan, depending on your culture, your social environment, what you have access to, can affect how you grieve or how you interpret death, your death and others' death. And as with the beginning of life, death is also a complex interaction of biological, psychological, social, cultural, and life cycle factors. Perspectives on what happens after death is also an interaction of these forces. So I want to thank you guys for taking my course this semester. You guys did really well. Your projects, your PowerPoint projects really did well. Your discussion groups, really came out, and you had some great ideas, really using the evidence, really thoughtful, really respectful of each other. It's really been an honor to be able to read your post and to see you guys interacting with each other. I wish you the best. Take this knowledge. What I want you to do is, this is a lifespan course that we all are part of this lifespan cycle. I want you to take these, what you've learned in this class, apply it in your life, apply it in your college, even if you've learned, just a little bit about you as development, and how we interact with our peers, and understanding that you'll understand people better, you understand your reaction, your communication with others, and how are you going to talk and communicate and go on with your careers through this. So I thank you for your participation. You guys worked really hard, and I wish you the best in your future endeavors, and have a great rest of your school and your career. And feel free to email me if you need anything further, going further into your school or your career aspects. And good luck on the final.